Assalamu alaikum. So we come back again with our fourth lecture on rheumatology and bone disease. We are going slowly but steadily. I hope the previous three lectures you have gone through them and the core concepts, the very few things that I discussed about with you, you are clear about that. So be confident about those conceptions. So now we will start today from the investigations of rheumatological disease. So the first investigation that in this textbook discussed is joint aspiration. So joint aspiration with examination of synovial fluid is pivotal in patients with suspected septic arthritis, crystal arthritis, or intra-articular bleeding. So joint fluid aspiration, this investigation, what are the indications? Not any kind of arthritis. So this textbook says mainly three types of conditions are indications for joint aspiration. Those are suspected septic arthritis. When you suspect septic arthritis, we will learn about it in details later. Crystal arthritis, that means gout, pseudogout. These diseases are called crystal arthritis. Septic arthritis, crystal arthritis, or intra-articular bleeding, we may find this in hemophilia patients, intra-articular bleeding. So these three are indications for joint aspiration: septic arthritis, crystal arthritis, and intra-articular bleeding. Intra-articular means, intra means inside and articular means joint. So bleeding inside the joint is called intra-articular bleeding. So it should be carried out in all individuals with acute monoarthritis, and samples should be sent for microbiology and clinical chemistry. So we have to focus on this part of the line. So there is another indication: any patient presenting with acute monoarthritis. Monoarthritis means inflammation of a single joint, just one joint is inflamed. So if the presentation is like that, acute monoarthritis, that means a patient comes with swelling, tenderness, pain in only one joint of his body for for say few days, okay, for acute duration. So that is a presentation of acute monoarthritis, and that is also an indication for joint aspiration. So we will aspirate the joint and we will send the samples to do which investigations? For microbiology and clinical chemistry. Okay, so microbiology means we will do gram staining, FB staining if we suspect, and then we can do culture and sensitivity. And then clinical chemistry means we will see the cell count, we will see the glucose content there, etc., etc. So next, it is possible to obtain synovial fluid by aspiration from most peripheral joints, and only a small amount is required for diagnostic purposes. That means you don't need a huge amount of joint fluid to do your diagnostic procedure. Only a small amount is sufficient. Normal synovial fluid is present in small volume. So these are the characteristics of normal synovial fluid without any disease. Okay. So the synovial fluid normally, the small volume, and it is clear, either colorless or a bit pale yellow. So both these colors are normal, colorless or pale yellow. And normally the viscosity of the synovial fluid is high, normally high viscosity. So some characters of normal synovial fluid is, it is small volume, clear, colorless or pale yellow, and high viscosity. Okay, and contains few cells. With joint inflammation, when the joint is inflamed, the volume increases. So it was normally small volume, but in case of arthritis, the volume of the synovial fluid increases. The cell count also increases, and the proportion of neutrophils rise, causing turbidity. And so the neutrophil count also rises. So we told you earlier that in clinical chemistry, we will see the cell count. So the neutrophil count will rise. And because of this rising neutrophil count, the fluid will become turbid, which is normally colorless or pale yellow. and the viscosity reduces. This is a bit, it may sound paradoxical to you, but we have to remember this. Normally, the synovial fluid has high viscosity, but if the joint is inflamed, the viscosity of the synovial fluid reduces. So why it reduces? So this is explained here within the first bracket, due to enzymatic degradation of hyaluronan and aggrecan. So we learned about hyaluronan and aggrecan, the components in the articular cartilage in the last class. So this hyaluronan, aggrecan, these substances are degraded by enzymatic degradation. So because of their degradation, the viscosity of the synovial fluid decreases. Okay. So if after joint aspiration we find a turbid fluid and high neutrophil count, so it indicates septic arthritis, crystal arthritis, and reactive arthritis. Reactive arthritis. So finding of turbid fluid and high neutrophil count in the joint fluid, there are three differential diagnoses: septic arthritis, crystal arthritis, and reactive arthritis. Okay. Then a less important information is non-uniform blood staining usually reflects needle trauma to the synovium. So we may sometimes find blood-stained joint fluid, but this does not necessarily always indicate that there is intra-articular bleeding. So it may be traumatic due to a needle prick. So in that case, the bleeding will be non-uniform. Okay. And uniform blood staining is most commonly due to a bleeding diathesis. So in case of hemophilia patient or like some diseases like that, there will be spontaneous intra-articular bleeding and the joint fluid will be hemorrhagic and uniformly hemorrhagic. Okay. So besides the bleeding diathesis, it may occur due to trauma or pigmented velonodular synovitis. You don't need to memorize this term. Okay, we move on. A lipid layer floating above blood-stained synovial fluid is diagnostic of intra-articular fracture and is caused by release of bone marrow fat into the joint. So it has said that if in joint fluid, we see that suppose uh, here there is joint fluid in this container and we can see some fat floating over the blood, the blood stained joint fluid. The joint fluid is blood stained and we can see some fat droplets or fat globules floating over the blood stained joint fluid. So this kind of appearance indicates there is intra-articular fracture because these yellow fat globules or fat droplets, these come from where? From the bone marrow. Bone has fractured and inside the bone there is bone marrow. These bone marrow fragments here are floating here. So this is a very important information for single based answer questions, SBA type questions that are commonly appear in the MRCP questions or FCPS questions. So this is here. So when they describe in the vignette that you have aspirated the joint fluid and the appearance of the joint fluid is like this, that the joint fluid is blood stained and there are floating yellow globules or they may directly mention that floating fat droplets. So what is your diagnosis? So this is intra-articular fracture. Okay. So let's move on. So we studied earlier that crystal arthritis is one of the indications of doing joint fluid aspiration. So if that case is a case of crystal arthritis, the findings may be different type of crystals we may find in microscopic examination of that joint fluid. So urate crystals are long and needle shaped. It is very important to remember. Very important for MCQ. We can find this here, the urate crystals. They are long and needle shaped. Okay. And then Another type of crystal commonly, that is the calcium pyrophosphate crystal. Those are rhomboid in shape. Rhomboid in shape. So these are the calcium pyrophosphate crystals. These are rhomboid shape. Okay. Again, another important characteristics of those crystals, the urate crystals are negative birefringence. They show negative birefringence, and the calcium pyrophosphate crystals, they show positive birefringence. We have to remember that. So three differentiating features. The urate crystals are long. These are shorter calcium pyrophosphate crystals. The urate crystals are needle shaped, and the calcium pyrophosphate crystals are rhomboid shaped. And the urate crystals show negative birefringence, and the calcium pyrophosphate crystals show positive birefringence. So these are the features. Let's move on. So we are moving on to plain X-rays, another important investigation, very important investigation in rheumatology and bone disease. So there are some X-ray findings of osteoarthritis. When we will study osteoarthritis as a topic, we will learn more, we will understand more. So in this section, there are some important features that we will find in X-ray of osteoarthritis patient. These are joint space narrowing. That means there will be X-ray. There will be X-ray findings. Suppose this is a joint. This is a joint. So this is a bone, long bone, another long bone, and between them there is a joint. So this is a joint space. Okay. Joint space narrowing means in osteoarthritis there is inflammation, there is decay, there is degeneration, and osteophyte formation. So then, due to the disease process, the joint space will be narrowed. Joint space narrowing. Okay. Then another finding is osteophyte formation. Okay. So osteophyte means in osteoarthritis, there are some bony outgrowths. There are some bony outgrowths. Let's say from this long bone, there is some bony outgrowth from here, from here. So normally not that large outgrowths, a little small outgrowths. When we will see real radiological pictures, you can find that. So some bony outgrowths are osteophytes, and these are typical findings in the X-ray of osteoarthritis patients. Another finding is subchondral sclerosis. What do you mean by subchondral sclerosis? Subchondral sclerosis means, so say this is a long bone. So in the end of the long bone, there is articular cartilage. Okay, articular cartilage. So cartilages, the cells of the cartilage are called chondrocytes. So there are chondrocytes in this area. Sub means below. So below this cartilage, there is sclerosis. That means fibrosis. Due to the inflammatory process, there is fibrosis. And this is called subchondral sclerosis. So in X-ray, a fibrosed area will be visible. Okay, it will be radio opaque. So this is subchondral sclerosis, another finding in osteoarthritis. Bone cyst. So bone cyst, that means this is a bone. You will find some cystic area inside the bone. Let's say this is a cyst-like area, little bit transparent or a bit radiolucent areas, a little bit circular. So these are bone cyst, and these are also a finding of osteoarthritis. Okay, so we have learned some findings typical in osteoarthritis, and those are joint space narrowing, osteophyte formation, subchondral sclerosis, and bone cyst. Okay, let's move on. The next information is erosions and sclerosis of the sacroiliac joints and syndesmophytes in the spine. may be observed in spondyloarthritis. So we all know about the sacroiliac joint, the joint between the sacrum and the hip bones, one on the right side and one on the left side. So these are the sacroiliac joints. So here it is the sacroiliac joint, one sacroiliac joint and another sacroiliac joint. So when there is erosion and sclerosis of the sacroiliac joint and syndesmophyte in the spine, spine means vertebra, which lies behind this area in above the sacrum. Okay, so these are syndesmophytes in the vertebral column, or spine. These may be observed in spondyloarthritis. So the erosion and fibrosis of the SI joint and syndesmophytes in the vertebral column, these may be found in spondyloarthritis. Okay, and then let's move on. In tophaceous gout, well-defined punched-out erosions may occur. So this is a variety of gout. In tophaceous gout, so there will be punched-out erosions. Okay. And then let's move on to another important finding, rheumatoid arthritis. What do we find? There are erosions of joint space narrowing. We also found this in osteoarthritis. So erosions, joint space narrowing, and periarticular osteoporosis. What do you mean by that? Periarticular osteoporosis. So periarticular means this is a long bone, this is another long bone, and in between them, this is a joint. Articular means joint, peri means around. So the part of the long bones around the joint, this show osteoporosis. Osteoporosis means decay of the bone. The bone is decaying, osteoporosis, and that is a different disease. We will learn that in detail later. So there is periarticular osteoporosis. This is a typical finding of rheumatoid arthritis. Okay, so extra findings of rheumatoid arthritis are what? Erosions and joint space narrowing, which is also found in osteoarthritis, and periarticular osteoporosis. And extra findings of osteoarthritis are joint space narrowing, osteophyte formation, subchondral sclerosis, bone cyst formation. Those are findings of osteoarthritis. Okay. In osteoarthritis, the joint space narrowing is focal rather than widespread. So joint space narrowing is found in both osteoarthritis and rheumatoid arthritis, but in osteoarthritis, the joint space narrowing is focal. That means only in a part of the joint, not the whole joint. So joint space is narrowed in a portion of the joint, not the whole joint. But widespread joint space narrowing is found in rheumatoid arthritis and other inflammatory arthritis. So in rheumatoid arthritis, there is a uniform joint space narrowing. Okay. Next, radionuclide bone scintigraphy. It is an advanced investigative procedure, but we have to know about this. We'll have to get an idea about that. So radionuclide bone scintigraphy is mainly used in the diagnosis of metastatic bone disease and Paget's disease of bone. So two indications are here. In case of malignancy, when a primary tumor has metastasized to bone, so in that case, find out the metastasis, we do radionuclide bone scintigraphy. And also there is another bone disease which is called Paget's disease of the bone. We will learn about that later. This is also an indication for doing the radionuclide bone scintigraphy. So bone scintigraphy, what do we do there? It involves gamma camera imaging following an intravenous injection of technetium 99M labeled bisphosphonate. So we inject the patient with bisphosphonate, which is labeled with a radioactive substance, which is 99M technetium. Okay. After injecting that radioactive substance, we take images of that area through gamma camera. Okay. So that is the basic mechanism of radionuclide bone scintigraphy, which we do in bone metastasis and Paget's disease of the bone. Okay. So this box 26.3, radiographic abnormalities in selected rheumatic disease. So discussed about some of the findings in the text section. So let's read it again. In rheumatoid arthritis, there is periarticular osteoporosis. We told it that there are erosions, joint margin erosions, and there is joint space narrowing, which is uniform. Uniform joint space narrowing in rheumatoid arthritis. Uniform joint space narrowing. Okay, let's move on. Okay, then osteoporosis. Osteoporosis, there is decay of the bone, so there is osteopenia. That means reduced opacity of the bone. Vertebral fractures may occur. Non-vertebral fractures may also occur. There is cortical thinning. That means thinning of the outer portion of the bone. So these are the radiological findings in osteoporosis. We may find some fractures, vertebral fractures or non-vertebral fractures, osteopenia, and cortical thinning. In Paget's disease of the bone, there is bone expansion. There is bone expansion. There is osteosclerosis and lysis. There are some pseudofractures. These are findings in Paget's disease. So bone expansion, there is pseudofractures, osteosclerosis, and osteolysis. Okay. In psoriatic arthritis, we may find sacroiliitis. So psoriatic arthritis is one of those spondyloarthropathies. So there we may find sacroiliitis, syndesmophyte, etc. In osteoarthritis, there is joint space narrowing, osteophyte formation, subchondral sclerosis, and subchondral cyst or bone cyst formation. These are the findings in osteoarthritis. Okay. Then let's come to magnetic resonance imaging, the MRI. Okay. In MRI, we are not learning about detailed findings of MRI. We have to memorize two things. The T1 weighted sequences. There are lots of slices, lots of sections in MRI that are used. The T1 section, that is useful for defining the anatomy, and T2 is useful for assessing the tissue water content. Just remember these two lines. T1 for anatomy and T2 image is useful for assessing the tissue water content. One for anatomy and two for tissue water content. Next, ultrasound. We can use ultrasound to see about the synovial cavity, whether it is inflamed or not, or we can do some ultrasound guided injection of the joint and bursa. Okay. So this is an MRI of both hands showing joint synovitis. You can see that there are some hyper intense or opaque areas in some joints. Okay. This is the left wrist joint. This is also a hyper intense area. That means it is more white than the normal soft tissue around it or bone tissue around it. Okay. So extensive enhancement consistent with synovitis in both wrist at the second metacarpopharyngeal joint. This is the second metacarpopharyngeal joint and proximal interpharyngeal joint of the right hand. So see, this is the proximal interpharyngeal joint. This is inflamed and it is hyper intense. This is an ultrasound image showing synovitis. So this is a black shadow. This is fluid. Black means indicates fluid. Okay. So ultrasound is also used in the differential diagnosis of giant cell arteritis, GCA. This is also called temporal arteritis, to look for evidence of thickening of the vessel wall in the temporal or axillary arteries. Okay. Then let's come to DEXA, dual X-ray absorptiometry, DXA, or sometimes it is called DEXA, or dual energy X-ray absorptiometry. So you can call it either. Next, the DEXA is used to measure bone mineral density. So the mineral density, how is it inside the bone? How dense is mineral content? So we use DEXA method to evaluate that. And DEXA has a key role in the diagnosis and management of osteoporosis. You have to remember this. Diagnosis and management of osteoporosis, the key investigation is DEXA, DXA, DEXA. So dual X-ray absorptiometry. Measurement at So the DEXA, the bone mineral density, but BMD, where we measure this, there are some specific sites. The lumbar spine. One is lumbar spine. Remember this, lumbar spine. Another is hip, and sometimes there is forearm. So these are the three areas where we do the BMD score through DEXA. Okay. So the lumbar spine, the hip, and the forearm. Lumbar spine, the hip, and the forearm. The lumbar spine, the hip, and the forearm. Okay. Let's move on. So this is a typical BMD figure. Hip bone is used to do the scoring. So left hip dual X-ray absorptiometry or DEXA scan. Okay. So BMD score, there are some types. The BMD T score. T score means it reflects the number of standard deviations by which the patient's BMD value differs from that in a young healthy control. So in BMD scoring, we compare the patient's results with another person. Okay. So when that another person is called a control. Okay. So in T score, the control is a young, healthy person. Young and healthy person. Our patient may be an old person, but in BMD T score, the control must be a young, healthy person. Okay. BMD T score. Osteoporosis is defined to be present when the T score is minus 2.5 or below. So the T score is less than equal minus 2.5. So it indicates osteoporosis. And when the BMD T score is between minus 1 and minus 2.5, this is called osteopenia. And normal BMD is defined to be present when the T score is between minus 1 and below plus 2.5 plus. So more than 1 minus 1 and within plus 2.5. This is the normal value. So let's discuss it again. So the normal value of BMD. So the normal value is between minus 1 to plus 2.5. So in osteopenia, it is between minus 1 to minus 2.5. Minus 2.449 to be specific, minus 2.49, less than minus 2.5. Next, in osteoporosis, it is between minus 2.5, minus 2.5 or below, minus 2.5 or below. Okay, this is the findings of the BMDT score that we need to know. Okay, I hope it is clear to you. So in next we will finish our today's lecture here. From the next class, we will start discussing about the hematology. So till then, bye, stay safe.